So, thank you everybody that has joined already. And if you pop on later, welcome. And you can, if you miss it and you're watching this on a recording, thank you for watching the recording. I'm going to just really quickly introduce myself, introduce Recurrent Pregnancy Loss Association, introduce Dr. Ryniec, and then we'll go ahead and get into the Q&As. So my name is Megan Hansen. I am the co-founder and board president of Recurrent Pregnancy Loss Association, or RPLA, which is a 501c3 nonprofit organization focused on accelerating research into causes of and treatments for recurrent miscarriage and providing support to families that have been impacted by recurrent pregnancy loss. And this week we are doing a lot to just raise awareness around the condition of recurrent miscarriage and make sure that the community knows that we're here to support them. But we wanted this conversation tonight, because it's National Infertility Awareness Week, to be a little more broad. And so we're talking about the fertility relationship between the patient and physician overall, not just specific to pregnancy loss. So tonight I have here with me Dr. Jessica Ryniec. She is a fertility specialist at CCRM Boston. She received her undergraduate degree from Wake Forest University and her medical degree from Georgetown University. During her residency for obstetrics and gynecology at Rutgers Robert Wood Johnson Medical School, she received the Excellence in Female Pelvic Medicine Award and recognition for outstanding accomplishment in women's health. After residency, she completed her fellowship in reproductive endocrinology and infertility at University of Vermont Medical Center. And she has presented her research at medical conferences like ASRM. She's authored several publications for peer-reviewed journals. She works at CCRM Boston, so she lives in Boston with her husband and 2 children, and she is one of our board members. So Dr. Ryniec, I'm so happy to have you here with us.
Yeah, I'm excited. I think this is going to be a great talk, and hopefully we have a lot of people watching, but otherwise we post it, and I think it's going to be some good info for people.
Exactly. So I read your bio, but maybe before we dive in, tell us a little bit about yourself and why'd you pick this specialty? Why this population of patients?
Yeah, so as you said, I'm from Massachusetts, and that's where I was born and raised. And family, I'm part of a big family, have two big brothers and 2 younger sisters, and so family has always been really the most important thing to me. And it kind of naturally came about that I wanted to be in this field. I kind of was all over the place in medical school, but as soon as I did my OBGYN rotation, I just totally fell in love. And then when I discovered this particular specialty, it just was perfect for everything. It's surgical, it's clinical. There's so much research that still needs to be done and work to be done to help people. And then I get to be part of helping people grow families, and it's just the most wonderful thing I could think of to do. And so, every day I go to work and I love my job, and I get to do such amazing things. So it was just perfect for me.
Awesome. And if you guys don't follow, Dr. Ryniec has sort of a mad TikTok game and really educational posts. So I encourage everyone to go ahead and follow her if you don't already.
Oh, thank you.
So I know, we'll talk about the relationship between sort of the fertility doctor and fertility patient, but some of what we talk about will also be relevant to just, I think, doctor-patient relationship more broadly.
Yeah, definitely.
So in saying that, what I would like to do first is just kind of cover some of the basics between what does the reproductive specialist do differently from the OB-GYN or the maternal fetal medicine doctor? How does the work divide up between those 3 specialties?
Yep. So there's obviously a little bit of overlap, right? Because it's all women's health, but in order to do either of the subspecialties you mentioned, REI or MFM, maternal fetal medicine, you have to do an OBGYN residency. So we all have done obstetrics and gynecology for 4 years after medical school, learning how to deliver babies and also do gynecologic surgery. So we get that basis from residency. And then maternal fetal medicine and reproductive endocrinology and infertility are both fellowships, so it's an additional 3 years of training. MFM basically focused on high-risk pregnancies and managing a woman once she becomes pregnant through delivery and after. And so that would be, people who are at higher risk of medical disorders during pregnancy, higher risk in pregnancy for whatever reason, and they're followed by the MFM docs. Whereas REIs, fertility specialists, we kind of work on the other end of things, helping couples to achieve pregnancy or single people to have children and be pregnant. And we also spend a lot of time focusing on reproductive hormones. It depends on you can kind of further subspecialize within REI and either do it all or focus mainly on infertility or focus mainly on reproductive endocrinology. And so for that fellowship, we still do quite a bit of surgery. We are trained in infertility, and then we also are trained in managing reproductive hormones, which would be thyroid, prolactin, and then obviously the estrogen, progesterone, ovaries, and brain.
Awesome. Thank you. That's actually really helpful. And then some other basic questions, because when people are doing like research on various physicians, sometimes you see the MD after a person's name, and sometimes you see the DO after a person's name. So what is the difference there, and does it make...
So for the most part, they're very similar. I mean, we go through pretty much all of the same training except for slight differences. And then once we graduate from the type of school, medical school wise, so it's either medical school or osteopathic medical school, we will have gone to similar residency programs and similar fellowships. So it's really down to like the initial medical training. And so MD is a doctor of medicine, and traditionally kind of more focused on like seeing symptoms, treating diseases, based on that part of things, like more like evidence-based process for treating disease. Whereas osteopathic DO, traditionally, again, because there's a lot of overlap now, was more care of the whole person type approach. And so they still do all of the same classes that an MD does, and then on top of that do 200 hours or more of this osteopathic manipulative medicine training, which focuses on the musculoskeletal system and using the body in healing itself. And so that's the additional training that they do. We also do slightly different exams throughout our training, but usually we end up in the same residency programs, same fellowship programs. I think, again, kind of like the traditional difference was that a lot of times DOs would end up more in primary care, whereas MDs were more likely to specialize. But I know several amazing DOs that are REI trained physicians, and so there's a lot of overlap.
And then the board certification the same? That was the other question I had to ask. Like when you see that somebody is, okay, I'm a board certified this or whatnot, is that certification the same for either route? And what exactly does that mean? And like, why should a patient be concerned about, or not concerned, but like pay attention to that? Why should we pay attention to that?
Yep. So board certification, like after you do your initial set of exams and things from medical or DO school, is very similar. And so that's basically done by the board of whatever specialty. And so we have ABOG, which is the American Board of Obstetrics and Gynecology. And for reproductive endocrinology and infertility, we actually have to be eventually double board certified. And so first, after residency, we do a written exam for general OBGYN. and an oral exam for general OBGYN. And then we do a written exam for REI and then eventually an oral exam for REI. And being board certified basically means that you've committed yourself to continuing to learn and be held to kind of a higher standard in the profession. You know, I could have graduated from residency and not become OBGYN certified. I could be an REI and not be board certified, but knowing that your doctor is board certified is kind of knowing that they're committed to the profession and to continuing to update themselves on the new things that are coming out. I do like to point out, just because I am in this situation right now, you know, when you graduate from fellowship, there is some years, 3 to 8 years, that you are not yet board certified because you have to do the board certification process. So what you really want to look for from an REI standpoint is fellowship trained, at least, if they've recently graduated, and then board certified eventually, and board eligible, meaning they passed the written exam and they're gathering cases for the oral exam.
Yeah. No, thank you. That's actually really important, is like thinking about the like what phase your physician is in and what is sort of appropriate for that point in their career. That's like a really good point for people.
Mm-hmm. And it's a long process. And right now it's like totally flipped because of COVID, because things are being delayed. We weren't able to have oral exams this year. And so, you know, it's crazy.
The world is crazy.
Yes.
Last question, I guess, sort of at the upfront piece is, and this is sort of maybe this I'm sure spans all specialties, not just REI, but how should patients think about the difference between trying to go to an academic medical center for specialty care versus a private clinic for specialty care? What are sort of the pros and cons, or the reasons for thinking about going one route versus another route?
Mm-hmm. So I think that for infertility in particular, there's a lot of blurring, again, like the MD and DO, between the lines. So, you know, realistically, an academic medical center is going to be training residents, training fellows, and practicing like the whole scope of the field. And so, you know, when I did my training, we did all reproductive endocrine, reproductive surgery, infertility, and research. And so that is kind of always been the power of the academic center, whereas they are kind of a little bit more controlled by the academic center. So they're university affiliated. There's people above them governing, you know, how things happen. Whereas private is private, as in you know, you either own the practice yourself or you work as a partner in the practice. And I think a lot more often in private practice, there's more of a focus on infertility specifically within the field. And it used to be, I think, that private was much more strongly clinical than research oriented. That being said, there are some amazing private groups that are national groups, including CCRM, you know, RMA, Shady Grove, and they do so much research and build so many of the techniques for fertility. So there, again, is a little bit of blurring of lines, but I think that that's kind of the main difference, is that at an academic center, you're more likely to get kind of the full scope. And so, for example, you know, I get people who come and see me for PCOS that don't necessarily want to get pregnant right now. And so it's harder for me to treat that from a CCRM IVF standpoint.
Yeah.
I certainly have a lot of practice in doing that from my training, but it's not the focus of the private practice that I am in. Whereas an academic center would be able to maybe treat someone with PCOS from the get-go, and then when they're ready to become pregnant, also do that, which, you know, we're totally capable of, but it's just a little bit different. I do think with private centers, you're more likely to have kind of a direct doctor to patient relationship because there's not a lot of sharing of patients. So, for example, I see many of the patients that my partners treat, and sometimes I'll do procedures for them, but for the most part, you know, I have my set of patients. They have, you know, Dr. Steyer and Dr. Zyman have their set of patients. We all take care of each other, but like there's a lot more ownership, whereas in an academic center, it might be a little bit, not saying that it's not possible, patient relationships can be great there too, but sometimes your time is demanded to be elsewhere by the university or academic center that's kind of in control.
Yeah, no, that's helpful. And I think honestly, like, so, and I'll say for myself, for any people that are watching, I saw two different well, I've seen lots of specialists on my journey, but I saw in particular two different reproductive endocrinologists and infertility specialists, one at an academic center and one at a private clinic. And I definitely felt that difference in sort of the, there was much higher touch at the private center, but it was like the level of care was the same. It was just sort of
right.
like operations in certain ways. So
yeah.
Absolutely. So I wanted to then talk about, like, I mean, and I'll say as we chat, feel free to ask me questions as well, because I think we're coming from the clearly the opposite sides of this conversation.
Yeah.
One of the things that I didn't know when I went in for my first appointment with a fertility specialist, and because you usually are scheduling like 4 months out, and so you go in and you're like, I've been waiting, I've been trying, I'm finally here. I like legit thought that I was going to get the answer in that first consultation, and and I was like, wait, what?
Yeah.
So tell me on your end, like, that, so here, that was my mental preparation for walking into that conversation. What are you doing on your end before that first consult with a new patient? Like, what's your process and what are you preparing for?
Yeah. So I'm very fortunate where the practice that I work at often will do like a patient intake with a nurse or one of our patient care coordinators ahead of time, so that I know, they've gotten their whole history, expectations, questions that they want to ask and things like that. And so I know a little bit about the patients before I see them. It's not always the case. Certainly I have people who weren't able to connect with the people ahead of time, but I basically am going through that whole history, kind of putting some ideas in my head as to what might be going on with them, making sure I am trying to approach it from where their expectations and what their specific questions are, and preparing in that way. And, a lot of it ends up being very similar between patients because, we end up doing very similar workups for everybody. But, I try to look at the history as much as we have, and then I still will have the patient or the couple say to me, I'll say, I got so much information for you. Thank you so much for doing that ahead of time, but I would really love to hear, like, if anything didn't come across in the paperwork or anything has come up, or like, tell me, what you are here for and what specific questions you have that you want to make sure we really get to. And then we'll do that and we'll go through the history, just confirming everything. And then I'll talk about basically what the initial workup will be and what those little things I was thinking of in the back of my head after reviewing their history. Yeah. And the other thing is if it's a second opinion, I try to have the records ahead of time so that I can, again, have a plan kind of in mind so that it's not just kind of like on the fly, especially for a second opinion patients, because they've been through so much and they have, not that everyone else hasn't, but like they have their prior treatments. And so I don't want them to come and sit and talk to me and have me be like, well, I don't know. So I want to make sure I have kind of like a plan in place. But you're right. A lot of times there's no answer from the get-go. It's like, it's nice to meet you. Let's review your history. And then like, this is how the evaluation is going to go. But really, let's meet back up after we do that to kind of really dive deep.
Mm-hmm. And what do you, so that people don't go in and they're not quite as like unaware as I was, what would you tell, or what do you wish that you could tell patients? Like, what do you wish that you could tell people that haven't come in yet to think, care for that?
Yeah, I think it's always really helpful when people have questions written down, because as I said, I think it's so important to like understand where someone's coming from, and I really want to make sure I address what specific questions they have. I also think it's helpful, if possible, to have multiple people there, whether you're in a couple or, if you're single, if possible, to have a friend or a sibling there. And that's because, a lot of times the conversation centers around one person, even in a couple, because, couples will sometimes identify, well, I have PCOS, and so he's not the issue, which I never want to say anyone's a problem or an issue. But it just kind of always happens that it ends up kind of focused on one person. And so having two people there, I think, is really helpful for someone to be like writing things down and everything. I want people to know that, like, I understand it's been, probably a year since you've been trying to conceive. You were ready a year ago, and now you're here seeing me, and I'm telling you we need to wait longer, but that it's worth it, and we will do our best to figure out what's going on. I find myself saying that all the time. I also find myself saying all the time, like, my hope is you don't get your next period and I never see you again. And that's not in the meanest possible way. Like, I would love for you to just see me get pregnant and not come back. But, I feel like people get worried sometimes. They're like, well, I'm seeing a fertility specialist. Like, do I need to stop trying? Or like, what if I get pregnant? Then it's like, but I think that's great.
Yeah.
So, those are kind of the big things there.
And I will echo exactly what you said, like, about having someone with you, because I know that when I was sitting, like, every time I would sit down to talk about test results or to like put a plan in place, I found myself, like, it was like I was hearing it sort of, and I was just nodding along. And then
right.
would say, like, okay, how does that sound? And I'm like, yeah, that sounds great. I'm totally tracking. And I would, 5 minutes later, I have no idea what just transpired. And so, like, if you're partnered, great to have a partner there. If you are, if you're single and trying to have a child, or, if your partner can't be there, like, I know I brought my mom to some appointments, be there, and it just does help to have somebody else listening that's not quite as, I don't know, that is a little bit less emotional in the moment.
Yeah, I get it. And, I think that another nice thing that my practice does, and I'm not sure if this is CCRM around the country, I'm sure it is because we do a lot of the same things, but we set up a nurse call. Anytime someone has a new patient call, we automatically set up a nurse call for 2 or 3 days later, so that, I always say at the end, I am sure you're going to get off the phone and you're going to come up with questions, or you're going to be like, wait, what did she say? I don't get that. And so we always have a nurse call in place a couple days later for them to go over what we talked about, like, and answer any questions that have come up, which I think is really helpful for that same situation. Like, if you are coming to the appointment alone, or like if you're both equally invested, which oftentimes couples are, it's kind of like we have a touch point in place for that.
Yeah, no,
question answering.
That's a really great idea. I like that. So now after you get the first, I know, and I posted about this on our Instagram feed just the other day, about the number of people who have unexplained infertility, unexplained recurrent pregnancy loss. So when you, I want to ask, like, I know what that feels like for me. What does it feel like for you when after that, after you've done that initial workup, everything comes back and there is nothing that, like, really stands out as being really that far off base?
Mm-hmm.
What does that feel like for you as a physician, and how do you manage that with the couple that clearly is having feelings of frustration and disappointment around hearing that?
Yeah. I mean, it's certainly frustrating and disappointing to me as well. And it's really hard. You have people that are coming, as I said before, like, they probably decided they wanted to have a child a year ago and they don't have a child yet. And they're coming to me as someone who's the expert and can help them achieve this goal. And so if I don't have an answer for them, it's so hard to explain that doesn't necessarily mean that there's nothing wrong. In fact, it means that there is something wrong, but we just don't have a test for it. And that's where, the research in this field is so important, because we need to figure it out. We certainly have treatment and we have knowledge about what are the best treatments options for unexplained infertility, but it's so incredibly frustrating from my standpoint as well to not be able to give answers, because I feel like there are so many times when I will do an ultrasound or do the HSG test for the fallopian tubes, and like everything is normal, and like you can just see the patient like break down, like, so there's nothing wrong. And I want to be like, well, this is a good thing, because we know these things are not wrong, but so many people just want that answer, and I can't give it, and so it's really hard.
Yeah. And I guess like it's so, like you're with people at this incredibly like vulnerable moment when there's that good news that's bad news because they've been really wanting to have the answer.
Right.
And I mean, I know like my doctor was phenomenal, and I still in my head have like weird anger, not anger,
Yeah.
like, but you couldn't figure me out. Like,
Right. Yeah.
how do, like, what is on your side? Like, how do you deal with the emotions that are being projected towards you? And what would you tell the people that are like in the room with you about expressing those feelings, or it's embarrassing
Yeah.
in front of somebody. Yeah.
Mm-hmm. Yeah, I mean, I think I just encourage people to like feel the feelings that they're having. I oftentimes also see patients and like, they break down and then they apologize to me, and they're like, usually I'm so brave, and like usually I handle this so well. And that I feel like breaking down and letting yourself experience that is being brave and handling it well. Not that you have to do that every day, but I try to reassure them that it's what they're feeling is normal, and try to get the support from family and friends that they can, and that we're going to try whatever we can to try to get an answer for them. And then again, it depends on kind of where they are in the pathway, right? So if it's just an initial diagnosis for unexplained infertility or unexplained recurrent pregnancy loss, we have steps that show, hopefully good results. It's a different conversation when it's unexplained infertility or recurrent pregnancy loss that has then tried multiple treatments and we still haven't had an answer or success. It's hard, and I never would imagine to say like that I experience this as strongly as the patients, because they're the ones that are going through it. But it's a tough field, like to be in it, like I feel like there must be, at least even from my standpoint, being in it for 4 years now, like such high burnout in my profession, because I feel like I feel the highs so much, and I really truly like am very affected when things don't go well. So it's hard, and I just try to encourage people to feel what they're feeling, and I haven't encouraged anyone from my practice to seek a second opinion, but I always, when I am answering questions on Instagram or TikTok or whatever, like encourage people to get second opinions. And so it's never anything that I would actually be offended by if someone did that, because sometimes it just takes fresh eyes, or someone who does something a little bit differently. And so like I would encourage that. I think if I, again, I'm new in my career as an attending, and so I think if we got to that point with some patients, I might encourage that. Not that I don't want to continue to take care of them, but it's tough.
Well, and I think that's, I'm glad that you brought that up, because, right, it's, I mean, I call this like sometimes with like my therapist as well, like when you're finding a new therapist, it's like, oh my gosh, now I have to break up with my doctor or break up with
Yeah.
but it is true that like sometimes you get to a point where you're like, okay, it feels time from my side to seek another opinion. And I'm sure that you kind of feel that also on your side. And so that's a delicate thing to handle. And so I'm glad that you addressed that. Have there been times when you've been working with like an individual or a couple where you feel like it's not a great fit, or you're not being able to address their needs, or they've said that to you? And how do you kind of navigate the realities of those types of conversations?
Mm-hmm. I haven't had that truly that experience yet. You know, I am sure that I will. And I certainly have patient interactions that it's like, well, yeah, that didn't actually click like as well as I usually feel like it clicks, but either it comes over, you know, the next few visits, or you know, it's just never like as strong a relationship, which is always disappointing. But you know, it's I haven't had any time where I felt like, you know, you really might be better benefited from someone else. I mean, I have certainly had patients even already that, you know, haven't come back for a second treatment. And so, you know, I know that they've gone elsewhere. So clearly it has happened in the reverse. And I totally get that. I would never be offended by that because this is such a vulnerable, emotional thing. And like, I feel like if it were me and I had failed treatment, or not failed treatment, but wasn't successful, I'd be like, I'm out of here. I'm going to get some more info
Yeah.
from someone else, you know? So, but I haven't had the situation yet where I have been worried about the relationship between me and a patient. There are patients that I've had that have come and I think had different expectations as for what um, they would get from me. And so, you know, that kind of goes back to I'm in a private clinic that focuses mainly on infertility. And so I've had several patients who have come, you know, to manage their PCOS from an endocrine standpoint, or to learn, you know, learn about their hormones, which I'm happy always to talk to someone about. I love hormones, like it's my job. But I feel like sometimes, you know, we don't have, there's a mismatch on like what they're coming for. So I've had that for sure, but nothing that when they've come for fertility treatment and I've offered it and I felt like it was not a good match.
And and that's a great question, because sometimes when you like read the profile of doctors on CCRM, but on really any clinic site, it'll say what their like particular interest and specialty is. So I don't know. I mean, I guess I never really know how valid or accurate that is, but at least for me, I'm always looking at that and saying, oh, great, you know, they have a particular interest in patients
Mm-hmm.
who have PCOS, or that, you know, deal with this particular type of issue. So I love it when that's like publicly out there, because you can try to kind of like find the right person right off the bat.
Yeah. Yeah. And I agree. And I think that that's really great too. And we try to be, I think, upfront about like what we're most interested in. Like obviously new in my career, and I still love it all. Not
Yeah.
that they don't love other things, but because I'm in a private group that is mainly fertility based, you know, I don't get to unfortunately manage, you know, the other side of PCOS, or I keep saying PCOS, but like endometriosis
Yeah.
from a non-fertility standpoint much anymore. And so that might be kind of like one of the big difference between private and academic practices, and something for people to know.
They'll have the kind of, I don't know, hematology, like kind of all in-house at an academic center.
Right. Yeah. Yeah. And I think it's also like, you know, it's great to know from a provider specific standpoint what they're interested in, but make sure also like to look at what the practice is, right? Like, you know, my practice is CCRM IVF. Not that we, again, can't take care of the other stuff, but we mainly do focus on fertility treatment, and not everybody has IVF. It's the name of the group, but it's more from a fertility standpoint than everything altogether. So that's another way to kind of know,
What you're
you know,
getting.
yeah.
Yeah. Yeah, no, that's a really good point. Like look at what the, like holistically, what is this practice focused on? And is this the of practice that's going to deal with the type of situation that you are encountering?
Mm-hmm.
I want to also go back to like what you were saying about, as we talk about emotions. I mean, I think that the mental health impact of infertility and pregnancy loss is no secret, and it is so real. And I think most couples, even though there is this huge, and individuals, I should say couples and individuals, anyone that's struggling to grow their family, feels really alone. Even though there's this whole community, it still feels so isolating and alone.
Mm-hmm.
And yet you're seeing all the people. So like, what can you do, or what do you do, or what do you wish you could say to these
Mm-hmm.
I'm sure there are common themes, and that, like, what do you want to tell us all?
Yeah, I mean, and I say that. I say, I know you're experiencing this on your own, and you know, a lot of times it's taboo to talk about in your family, or you don't have friends who've been open about it, and you don't think that there's anyone else that's experiencing it. And that's what this whole week is for, right? Like, I'm sure everybody knows someone who's gone through this. And so I say that, I say, like, this feels so alone, but I promise you, you are not. There is nothing that you did wrong to be sitting in front of me right now. And, I do oftentimes recommend, like, either support groups through social media, support groups for infertility in general, because I think that can help so much. I mean, it's a slippery slope for some people, because I know that there's a lot of, like, comparisons that can be made, like, if it's through social media, but I do think that there's a really great community here too. And I also try to be reassuring from the get-go about, like, what outcomes look like. Most people that come to fertility, not all, unfortunately, but most people do end up having their child one way or another. And the majority of those would have a live birth. And so, I try to reassure them too, like, that even though you're going through this and it's feeling really hard right now, like, the most likely outcome is that this is a successful thing.
Yeah. And I know, and it's so hard to hear. It's like,
I know.
It's hard to hear from the patient side too. Like, I remember hearing that, and it was this immediate, like, shrug off, like, whatever. I'm not hearing that, and
yeah,
like, don't talk to me about statistics. Statistics aren't. And so I can imagine that, you're on the other side of that, being like, no, I promise. I promise.
Yeah, it is. And, like, you get a vibe from different people. Like, if I start talking about statistics, trying to reassure, like, and they're like, I feel that from them. I'm like, all right, we're not going to talk about that right now. Like, let's talk about, you're in this place. Let's talk about mind-body things that you can do to kind of get you in a better place while we're doing this. So, I'm a big fan of acupuncture, a big fan of yoga, big fan of, like, whatever kind of meditative or, like, get your mind right technique works for you. And it could be, like, whatever, like drawing, reading, like, anything. And I'm so supportive of that. So if I feel like I'm throwing too much science and it's not being, like, absorbed well, I try to kind of go at it like, okay, well, let's find you support in this way while we're still trying to do the science to help you get your goals.
Yeah, no, and I think that's spot on, right? Because some people are encouraged, it's like, some people really love the practice of, like, what do they call it? Like, almost the toxic positivity. Like, some people just really want to, like, stay positive, think positive, and other people, don't come at me with positivity. I need to hold space for the potential negative outcome.
Yeah.
We're all different, and so you're reading that vibe and have to, it's and I love that, because it helps me also as, like, a patient to say, my doctor should be able to, like, respond to that. It is this interpersonal relationship, and that it should be two-way. Yeah. I'm going to switch gears a little bit and talk about another thing that I'm sure you deal with all the time, because pretty much any veteran fertility patient has spent quite a bit of time with Dr. Google. And so I would love to talk about that piece of it, when people come in and are like, I've read all these studies and this is what, and you're like, or yes.
Yeah, so it is kind of one of three ways, right? So either someone brings me something that has, like, widely been either disproven or not something that's supported by the evidence, and I try to talk them through that. And most of the time people are very realistic and listen and want to hear what I have to say on it. There are some people who will die on the hill of progesterone, being like, just, it's a thing. I'm sure you know. I'm sure everyone that's watching knows about the progesterone thing. But, I try my best to try to educate from my standpoint and like, oh, this is the study that you read. Like, let me show you why maybe this isn't the best study. And here's a different study that looks at it and that we feel is more of an appropriate study. And then there's times that people bring me things and I'm like, what?
Yeah.
I have literally never heard that before. And the way that I respond to that is, this isn't something that I have come across in my field, but let me look into it. And I have like learned a lot from patients. I have learned so much from having this Instagram account because I do, these weekly Sunday Q&As. And sometimes I'm like, I actually don't know enough about that as I should, and then there's people that bring me stuff that like really is like totally, I have no idea.
Yeah.
And I read about it and I learn about it. And if it's something that's real, I incorporate it. If it's not, I explain why I don't think so. And then there was a third way that I go about and I'm totally out of my head. So I'm not sure, but, I try to kind of objectively look at things and, people have brought me papers and I've read them and I try to see kind of what applies. If it's something that's not harmful or something that someone has an opinion on their treatment, I talk them through it. And if this is a shared decision-making relationship, I feel like. And so if it's not something that's harmful or I don't think that will impact their treatment, but might have a benefit, sometimes I do it. If I think that it's harmful or really not the best option for that patient, I explain why. But again, like, it's a shared decision. I never force anyone into anything. And so I always try to come at it from a learning opportunity for myself, a teaching opportunity for patients. And these are the facts, this is the evidence, and let's decide what makes sense for you.
So a couple follow-up questions there. I guess one, what would you recommend to people that are doing their own research in terms of, like, not everybody is as fluent in reading medical studies as years and years and years doing this. So are there any kind of quick tips for what people should be looking for when they are reading a medical study to do, like, see if it like passes the sniff test, so to speak?
Yeah. So you want to make sure that it's something that's peer reviewed, as in like this isn't someone who's published something on a blog, or I'm not that blogs are terrible, but like you got to have your resources behind the blog. You want like a first author, not forced authorship, like a first, I can't even, resource, you know what I'm trying to say?
Yeah.
Like an original resource or a blog with original resource linked to it. So you want it to be peer reviewed, as in other people in the field have looked at it. Randomized control trials are the gold standard, but obviously not always possible. So you want to be looking for something that like has some sort of a controlled process or lots of patients and that has been reproducible, because there's a lot in this field, because there is so much research that's still happening that, like, for example, reproductive immunology for recurrent pregnancy loss. There are so many labs that have found like one thing and it's come out of one lab and like they present their research and it's so compelling, but it's never been reproduced elsewhere. And so reproducibility, I think, is really important. Size of the study, randomized control as much as possible, and peer reviewed, I think, are really kind of the main things. And I encourage people, like, if you read this, like, as I said, if you read something, like, show me what it is. I will be happy to look at it. So, I think those are kind of the main things.
Yeah. And the reproductive immunology, I mean, like, it's, I'm sure it feels to you kind of like the progesterone thing, right? And it is, I mean, I definitely worked with a reproductive immunologist as well. What are there times, have you had patients that have been working with multiple care teams when you've had to coordinate with another care team about the right course of treatment? And talk a little bit about that, because a patient can really feel like in the middle between these two experts. And so that look like when it's working well? And what should patients know to be able to advocate for themselves in that situation?
Yeah. I mean, absolutely. We work with all sorts of different groups or people. And it does sometimes come up that there's a disagreement. You know, there is, to take the reproductive immunology for an example, I am sure there is something there, right? 50% of recurrent pregnancy loss is unexplained.
Yeah.
There's probably something there. It's just that unfortunately, so far, the research hasn't, you know, said that the different treatments that we try, and we try it sometimes, even if we don't have the good evidence, but there's just not good evidence yet to support it. And so, again, it's kind of like a laying it out for the patient and like being open and honest about what is the evidence, what, why something applies to you or doesn't apply to you, and helping kind of piece through it. And it's happened where we have differing opinions between one provider and the other. And I think that from my standpoint, just kind of have to lay out my, not argument, but my case for what my plan would be. And then, you know, all we can do is give the patient as best information, which obviously it can be way more confusing if two people are saying different things. But it's hard sometimes. For the most part, I feel like as providers, we can work well together. But that might be some of the situations where a patient wants to go elsewhere and get a second opinion to see, hey, is my REI wrong, or is my reproductive immunologist wrong, or like, what's your standpoint, you know? So I think that that's helpful in those situations too.
Yeah. And I guess like, yeah, I think, you know, it is. And that was, that was the situation I was in. And I guess I want to kind of take that a little further and talk just generally about like self-advocacy and empowerment when you're sitting on the other, you know, when you're sitting in my seat and the seat of the fertility patient. You already talked about some things I think that, that can help with this, you know, because it is a vulnerable position. And I think that we do have this like natural human instinct to like defer to the authority figure or the person that has more knowledge than we have. And so, you know, I love that CCRM always follows up a couple days later with the nurse to like address questions that maybe happened after the fact. But what other mechanisms do you put in place, or would you encourage your patients to put in place to make sure that they're always feeling comfortable with their treatment plan or feeling like their questions are fully addressed and answered? Like tips and pointers.
Yeah, sure. So I think everybody kind of handle this a little differently. I mean, as I said before, you know, coming with questions, coming with someone else with you, I think is just so valuable. I try to make myself really available, because I have the time right now. You know, I'm still building my practice and I have a great practice and I have a lot of patients, but I do still have some time to be able to address things with people. And so many of my patients either have my number or my email so that if something does come up, they can reach out to me. You know, the nurses that I work with at CCRM, you know, we spend a lot of time talking about my patients and like what we're looking for, so that, you know, if the patient reaches out to them, they know what I'm thinking, and that if the nurse can't answer it, they are always open to come to me. Like I try to like be open from that direction. I'm trying to think of what else. You know, I think just if you hear something from your doctor that doesn't seem to be going in the direction that you're trying to go, or isn't like the answers that you're wanting to get, to be open and tell them that. We're not, you know, I think for the most part, nobody would be offended if you were like, actually, no, that's like not what I'm saying. And it happens. You know, I think even a couple days ago, I was seeing a patient who wanted to be a single mother, or wants to be a single mother. And, you know, I start going down the whole pathway. Well, like, this is what we can do. You know, these are the treatment options. We could do IUI, we can do IVF, we can do this, that, and the other. And she happened to be an older patient. So I thought, you know, like, donor egg is an option potentially, like if we get there. And I always, with the donor egg, I'm like, this is not something I expect you to accept right now. I'm just mentioning it as a, you know, way down the road possibility. But she was like, you know, I actually like, I had been thinking about adoption. And then I thought if it's possible for me to be, you know, carry a pregnancy and be a mom that way, like that would be better. But I don't think I would go down the IVF path. I would never do the donor egg. I'd rather go back to adoption. And I was like, thank you for saying that, because I got carried away, you know, talking about all your options. And some people want like every contingency plan and some people don't. And so interrupting and saying like, hey, like you're going way too far down the road, or, you know, like, yeah, this does sound great. Like, I just try like to keep the communication open. It's more of a conversation. I really believe in the shared decision-making model. Like, I know I've said that several times, but I think that's kind of the best doctor-patient relationship that you can have. And so, you know, making sure people know that like they hopefully would feel comfortable in bringing up like, this doesn't feel right, or like, what if we do this instead? You know, so it's that kind of thing.
And you know, that's a great example. I remember when I sat down, because I moved in my process, my family building process, actually moved across the country, and so had to set up care with like a new team. And I remember in that first meeting, I was like, I'm exhausted. I don't know how much more I have in me, and I think I might want to move on to other options.
Yeah.
And I remember my doctor saying like, I don't think like we can talk about that. I don't think you're there yet.
Mm-hmm.
I'll tell you when I think you're there.
Yeah.
And to her credit, she did. I mean, she would have supported me, I think, early on, but you know, I remember her saying like, you've gone through all of the possible hoops. Like I'm fully supportive of you moving on if this is becoming too much.
What you want to do.
Exactly.
Yeah.
Which is a hard conversation to have too. That conversation.
Absolutely.
Family of like, we can keep trying to throw stuff at you, but
Yeah. And then it turns to more of a, you know, love is love and family is family, no matter how it's built.
Yep.
And you are already, you know, such amazing parents for doing this much for your future child, if that's what ends up being, because some people decide ultimately like, you know, my family is my partner, or my family is me and my family, and that's totally fine too, after going through everything that I'm like just so impressed by every patient that I see. But, you know, that's how you kind of start that conversation that, you know, families can be built in a million different ways. And unfortunately, it's time to maybe talk about broadening our ideas. And again, I always say, I'm bringing this up, but I know that you are not accepting this right now, and I'm not asking you to. I'm just asking you to know that, like, this is a possibility. I know how much you love this future child. It doesn't, you know, it might look different than what you thought of before, but it's still a valid way to build a family. And so it's like the hardest, well, the unexplained, that's always hard conversations too. But, you know, there's a lot of tough conversations for us.
yeah. No, well, we're nearing the end. I guess what any kind of parting thoughts or parting tips to fertility patients that might be watching this, or to other fertility doctors or OB-GYNs or MFMs,
Mm-hmm.
watching, whomever.
Yeah, I mean, I think that it's just really important to find a provider you trust. I know that oftentimes people end up with who their OB/GYN refers to, or who is closest, or who was the first link on Google, but you don't need to stay with that person. And so find a doctor that trusts you and supports you, and has this open conversation. You know, this is a shared thing. This is never the doctor makes your decisions. And then also make sure you feel comfortable sharing your goals, because that really like can change what the plan would be. You know, when I talk to new patients and they're in their mid to later 30s and they say they want to have 4 children, I am thinking of IVF before I'm thinking of other things. And so it's always really good to be open with your doctor about what your family building goals and where you're coming from a, a life standpoint, because everybody is different.
Right.
Everybody's experience, infertility is infertility, but everybody experiences it in a different way. So being comfortable sharing with your doctor kind of that part of it. And yeah, I mean, those are kind of like the two biggest things that I would say are really important when you're looking for a provider that will have a good relationship with you, one that's open to your ideas or teaches you about why you're doing what you're doing, and why things might not make sense for you or do make sense for you. I think that those are really key. I mean, what have you felt like has worked really well for you versus not?
For me,
Yeah.
I think, ooh, that is, see, now I feel like the ability the ability to be able to get questions answered after the fact, because I really do think that I'm guilty of, like, in the moment, just like nodding along and
Yeah.
really time at home to reflect and like review notes and do my Google researching about like what
Mhm.
actually mean, excuse my,
Yeah.
what does that mean when she said blank, blank, blank,
Yeah.
and to be able to come back and ask follow-up questions. That was really important to me. And I think, like I said, like there, I came to a point where I was really tired. I was physically tired. I was emotionally tired. And I needed to be able to share that with my doctors and
Hmm.
team so that we could deal with that piece to either allow me to move forward with treatment or pause or forward in a different direction. Like, it was really critical to create that space at that juncture.
Yeah. Yeah, I agree.
Yeah. So,
And then I think from, speaking to other providers' standpoint, I would just say, like, I'm happy to see someone before they start trying to conceive. I'm happy to see someone 1 month into them trying to conceive. I don't ever want people to get to the point where they are devastated by their ability or not ability, to have conceived yet. And so I feel like a lot of times general OBGYNs, and not everybody, and some people are fantastic, but a lot of times they'll be like, well, you're under 35, you need to try for a year. You're over 35, you need to try for 6 months. Or
you have to,
you've had two losses, or you've only had positive pregnancy tests, but never any ultrasound findings of a loss. Like, I'm not about that. And, I feel like sometimes referring providers are like, well, we don't want to refer something that, like, maybe isn't going to end up needing fertility treatment, or maybe, like, isn't, ultimately a problem. But I would rather reassure, this is what I'm here for. I want to help people. And if that's giving peace of mind and saying, like, you know what, we did your workup and everything does look good. And if you want to try for another 6 months or another year, you can.
yeah.
Or, if you really feel like having help right now would be very beneficial to you, let's do that too. So I would say that to providers that are looking to refer. Like, I think most of us would accept a referral at any point in someone's journey, because that's what we want to support people from this standpoint.
Well, thank you so much, Dr. Ryniec. It's been a pleasure to chat with you.
Yeah.
Um, I just, shameless plug for Recurrent Pregnancy Loss Association. I just want to make a quick mention before we close that, like I said, we are a 501c3 nonprofit organization. We are fully volunteer run, and we do everything with donations. So if you're inclined to support our organization and help accelerate research into recurrent pregnancy loss and help run events like this and provide additional resources to families, please visit our website or our Instagram page, Facebook page, and consider making a donation.